Good afternoon, and thanks for joining us for today's Healthline. I'm Courtney Butts, and today on Healthline, we are talking with a local orthopedic surgeon, Dr. John Mays with Willis Knighton Bossier Orthopedics, and he joins us now. Thanks for being here.
Thank you for having me.
Absolutely. So I can't help but notice you're in a sling right now.
Yes.
So you're a physician, but you were recently a patient. Tell me about your experience.
Right. I've done thousands of rotator cuff repairs, and I actually get to experience having it done on myself. My partner, Dr. Andrew Moritz, repaired my rotator cuff about 3.5 weeks ago. So I am a double expert on the physician and the patient side of this surgery. And I would have spoken about rotator cuff repairs, but it was just done a couple weeks ago. So,
right.
But I'll be happy to discuss that as well.
Yeah, absolutely. So it's pretty common. It's kind of normal wear and tear, would you say, on anybody's body? You can not everyone can expect to have it maybe, but it's pretty common.
It's very common, and there's a little misunderstanding there because rotator cuff tears, people think, oh, you've got a normal rotator cuff and then you have an injury and you have a tear, but it really doesn't work out like that. If you really look at rotator cuff repairs, they're primarily genetic. It runs in families, and it's just as hereditary as hip arthritis and other issues. So you're kind of predisposed to it from the way you're born, from the way your anatomy is designed. And then you have injuries that can occur over time, and they tend to occur gradually in stepwise manner, So you might have an injury, and then a month later you feel better, so you blow it off, but it never quite gets back to normal. And then usually you have that, the straw that breaks the camel's back that kind of sets it all off. And if you have a rotator cuff injury and repair on one shoulder, you have an over 50% chance of getting it in the other shoulder.
Oh, dang.
So it's not really from an injury, it's a combination of genetic factors, fitness, so a lot of people think, oh, you get a rotator cuff tear because you do too much. But in reality, the more you exercise, the more you use your shoulder, the more muscle and strength you have in your shoulder, the less likely you are to get a rotator cuff tear. So that kind of, after this, when it gets well, my goal is to get fit. So I got to get back to the weight room and I got to get fit, especially at my age. As you get older, obviously, you're more predisposed to getting these. And rotator cuff repairs are super common. A lot of people have them, and they're actually asymptomatic, meaning you can have a rotator cuff tear on an MRI or something and have zero symptoms, pain, or problems. So it's a pretty interesting disease, and the process is not completely understood, even by orthopedic surgeons. Right.
Yeah. So, and I'm sure this experience was great to connect with your patients.
Right.
Too.
Now I can tell them, they're telling me how bad it is. I'm like, hey, I know. I've had it myself. So it's going to be. It is an interesting process to go through, and it really makes me hopefully a better physician.
Yeah, for sure. Well, hopefully you're on the road to recovery. You mentioned you're doing much better now.
Oh, doing great. Yeah.
Cool.
Dr. Moritz did a fantastic job.
Cool.
And I'm following his direction. Like I told him, I go, I am the patient. I am not going to tell you what to do. You do your thing, and I'm going to follow your directions.
Awesome.
So it's kind of difficult, but I think hopefully I'm managing it.
Yeah. Okay. Good deal. Well, we can talk a little bit more about rotator cuff repair, but we are kind of shifting gears to a common complaint that you probably see in your practice: hip pain.
Hip pain. Yeah, it's very common. It's one of those the big three. Hip, knee, and shoulder are primarily what we do. Hip pain is kind of something I've semi-specialized in throughout my career. I've always done hip replacements, and I've also always done hip arthroscopy. So I'm one of those few physicians that does both of those. So typically when you're a young person and you have a sports injury, a labrum tear, you go to a sports medicine doctor. Or if you're an older person and you have arthritis, you go to a joint replacement doctor to get a hip replacement. But I actually do both. So there's a lot of crossover there, and it comes in handy because there's an age group and there's a lot of crossover in those two groups. So it's kind of interesting to see that throughout my practice. And there are very common things that you see every day, but there are also those zebras that come in. And there are some broad categories that are really poorly understood and managed. And if you want to, we can discuss those as well today.
Yeah, let's dig in. Yeah, you're the expert. Let's talk about all of that. I'm sure I'll be very enlightened by the time we leave here today.
Well, hip pain, when you're dealing with a younger patient, you're going to deal more with the congenital problems and the traumatic problems, the injury problems. So congenital problems are problems that people are born with. So people are sometimes born with conditions such as hip dysplasia. Hip dysplasia basically means that the ball and socket are not normal. They're broad categories. There's not normal, but there's a range of normal. But if you fall far outside that range, such as the hip is a ball and socket joint. You have the ball on the femur, and then you have the socket on the pelvis. Now the socket has to be a certain size. It has to be has to face a certain direction. And in some people, it's more common in girls for some reason. There's dysplasia where the socket is very small, or the socket faces the wrong direction, which is aneversion, which is faces too far anterior or too far posterior, retroversion. And that's called dysplasia. And you see pain in that age group, typically in the late teens, early 20s. Also, in the younger age group, you have another category which you might have heard of called labrum tears. Labrum tears are the lining around the socket of the pelvis, the acetabulum, where during a sports or an injury, like getting tackled in football or doing gymnastics, you can tear the lining around the socket, which is the labrum, and it's called a labral tear. And we see those occasionally, and that would be something that's common in the younger age group.
Right.
When you move into the older age group is where you get into more of the arthritis, you get into the hip fractures. Hip fractures are super common in older people, but you can get a labrum tear as you're older. There are more esoteric problems that can occur, but it's just a common problem. And there's also, like you said, a lot of crossover with back pain. Back pain is probably more common than hip pain. And oftentimes that pain can be referred to the hip, especially the buttock and the back of the hip joint. So in that situation, it can be very important to make sure you're dealing with the hip and not the back, or vice versa.
Right.
And even in those situations, there's a ton of overlap. But it's very important. If you have hip pain for a significant period of time, you need to go see a doctor. In hip pain, people often don't understand the hip joint is actually in the groin. So if you're having pain in your groin, in an arthritic situation, typically it's going to be what we call startup pain. Startup pain is when you're sitting in a chair, you're sitting in church, you're sitting in a movie, and you stand up. All of a sudden, that leg just won't quite go, and it's stiff and tight. And then after you walk for a little while, it might loosen up and get better. So that's called startup pain. And that's extremely common, and that's pretty much everybody with hip arthritis get that.
Yeah.
Labrum pain, things like that are going to be more pain when you're sitting, more pain when you're in unusual situations, when you're putting the hip through an extreme range of motion. And like I say, those are really two different age groups that we get into with those problems. The other really common problem that we see with hips is called bursitis. Hip arthritis is where the joint, it's the interface between the ball and the socket, which causes problems. In bursitis, occurs laterally over the side of your hip, and that's going to be the interface between ligaments, muscles, and bone. Really common. We see it a lot. It's something that can come on quickly with no really inciting event. If you lay on your side, it's going to be painful. If you sit for an extended period of time, it's going to be painful. So we like to see hip bursitis because it's much easier to treat and much less likely to result in a surgical procedure.
Yeah. Okay. I've covered a lot of ground there. So, so actually, personal interest. My mom has hip dysplasia, and didn't actually find out until she was in her 40s. So she had hip pain all her life, didn't really understand why, and now she has arthritis. And so, she's wanting to delay surgery, so she's getting injections and things like that. But is it kind of inevitable when you have something congenital like that where you're going to need to have a replacement?
Well, hip dysplasia is a little unusual because it can range from minimal, very mild to super severe. So the age it becomes symptomatic tells you a lot about how severe it is. So if she's in her 40s or 50s and it's just now become symptomatic, that's an indication that her dysplasia is not that bad.
Cool.
You know, if she was 19 and she was already symptomatic, that would be a much worse type of dysplasia. So when you get to be in your 40s, really over age 35, and you have dysplasia, you move into the hip replacement category. If you're under age 30, you really want to try to correct the deformity. And that, they're two totally separate categories. But when you're over 40 and you've had hip dysplasia and you're having symptoms, 9 times out of 10, you're going to go to a hip replacement. Hip replacements these days are fantastic. You know, they literally are life-changing events. And the surgical procedure takes less than an hour. You come in the morning, you get your hip replacement done, and you go home. And then pretty much, 6 weeks later or so, you're pretty much well. Maybe not completely well, but a hip replacement is far and away easier than trying to correct the actual deformity itself. So your mom, as far as putting it off, I would say 10, 15, 20 years ago, somebody came in with hip problems, hip arthritis, severe hip dysplasia, we would tell them to wait till you can't stand it anymore. Wait till you're miserable and then get your hip replacement. Because hip replacement wasn't as a mature technology as it is today. Nowadays, I tell people, if it's changing your life, if it's preventing you from doing things you want to do the hip replacement, because they're fantastic. Because you don't want to get your hip, pretty much a lot of people will do a hip replacement on, they'll get through it, it's really not that big a deal. And they always come in and say, I should have done this years ago.
Right.
I don't know what I was waiting on. So it's nothing to be scared of. And over 80% of people who have a hip replacement forget they have it. It is normal. Hip replacement is much better as far as symptomology after you get it done than a knee replacement. As far as a knee replacement, you're never going to forget you have a knee replacement, or it's less likely. But with a hip replacement, the majority of people get well and never know they have a hip replacement.
Right.
Doesn't impact their life at all, except make it better.
Yeah. Okay, cool.
But that's another broad category. I mean, there are people who have a hip replacement who still have hip pain. And there's a rare, but that's a group. For instance, when we do a hip replacement on somebody, we usually tell them, it's going to get better very quickly, but all of the symptoms, it should be normal within 6 to 12 months. Well, there are people who have a hip replacement and it's been a year, it's been 2 years, and they continue to have pain in their hip. So that's something where you want, if you're going to your regular doctor and he's telling you, oh, that's normal, you should have pain at 2 years, you're probably going to need to go get a second opinion.
Right.
Because there are a number of things in somebody who's already had a hip replacement that can be done to correct that. One of those is a hip arthroscopy. We actually do hip scopes on people who have had a hip replacement to go in and correct issues. So you don't always have to have the hip replacement revised. You don't necessarily have to redo or take out the hip replacement in somebody who does have a painful hip replacement.
Okay, very interesting stuff. So we do have our first caller. Crystal, thanks for joining us. And what's your question?
Hi, yes, good morning. I am calling to ask a question about my son. He had hip dysplasia, and I'm trying to see, is it, do the hardware stay in after hip dysplasia? That's one question. And then also to like for over the years, do he continue to, see the doctor once it's completed? It's been about 7 years.
So how old was your son when he had surgery on his hip? How old was he?
He was about 11 or 12.
Well, hip dysplasia in 11 or 12-year-old, there's a broad category there. I'm not sure what type of surgery he had, and it would depend on if it was his pelvis side or if it was his femoral side. but the majority of hardware that's put in for hip dysplasia in that age group is going to stay in for life. It's very rare that we ever take it out unless it's causing pain or a problem. So if he's pain-free, it's unlikely it's ever going to have to be removed. But if there are any questions, it's always a good idea to go get an x-ray and get it checked. You know, because sometimes when they're 11, they're going to a pediatric orthopedic surgeon, but if he's 18 or older, then he would be going to an adult orthopedic surgeon. And it's sometimes good if you've had problems when you're younger, when you get into that age group, to switch over to an adult orthopedic surgeon, because you're not going to probably go back to a pediatric orthopedic surgeon depending on how old he is.
Okay.
But I would be happy to
Okay.
see him if there are any issues.
Okay, awesome. What is your information? I can make an appointment with you.
I'm at Willis Knighton Bossier, John Mays, 212-7841.
Okay. Thank you so much. I definitely appreciate you.
Thank you.
You have a good day.
You too.
Bye-bye.
And if you're just joining us and you have a question for Dr. Mays, we are talking about hip pain or, you know, we've kind of covered a lot of different things, bursitis, arthritis. And George, thanks for joining us. And what is your question for Dr. Mays?
Yes, do x-rays usually show it, or bursitis? I have bursitis. Do x-rays usually show it, or does it just not show anything when you have bursitis?
Hip bursitis really doesn't show up on x-rays. And it has to be really severe to even show up on an MRI, to tell you the truth. So it's a diagnosis we make by history and physical exam 9 times out of 10. There's not really any advanced, if you have severe hip bursitis, it can be due to what we call gluteus tears, which is, you can get a rotator cuff tear of the hip, which is what a gluteus tear is. So like I have a rotator cuff tear of my shoulder, you can get a similar problem in your hip, and that would show up on an MRI, but none of those are going to show up on an x-ray. So, you know, if somebody comes in with...
What about things like physical therapy? I hadn't done any of that, but I just wondered about it.
Physical therapy, very important. When somebody comes in with hip bursitis, there's a number of things I'm going to do. Number one, you're going to do an anti-inflammatory medication, most likely, like ibuprofen, Aleve, you know, Celebrex, meloxicam. You're going to do, oftentimes, an injection with some steroid into the hip bursa, which is a 2-second, it's not a painful shot, it's a very simple injection to help the pain. And then you're going to do a series of stretches and exercises specifically to target the hip. Some people, I can give the exercises on a sheet and explain them to them, and they'll do them themselves. But a lot of times I do refer people to a physical therapist. You know, going to the physical therapist is like having a coach. So they can really take you by the hand and walk you through the whole process. But that's all part of the initial treatment. You know, if that doesn't work and somebody comes back in 4 to 6 weeks later and they're still having problems, typically at that point I will get an MRI. But x-ray is always part of the initial assessment, but it usually does not show anything on a bursitis problem.
Yeah, if you take an ibuprofen, if you take it like over a period of time, may it actually have some healing benefits, or does it just stop the pain? Or
it's pretty much just for pain. You know, ibuprofen in combination with Tylenol is a very very powerful pain medicine, but it's not going to do anything to make the hip get well. It's strictly for pain.
There's nothing you can really take to make it get well, right?
No, it's going to be
Okay.
exercise, stretches, weight loss. You know, the usual suspects, the things that don't come in a pill, are the hard ones. You know, I always tell my patients when they come in, you know, we're about to be a team, me, you, and possibly the physical therapist, and all of us are going to have to do our part. My part is going to be to explain to you what you need to do, but it's important that you do those. Exercise, stretches, super duper important for that.
And like one more thing, like should you walk less? Like I walk a lot, walk less, and play golf and that kind of thing, or is it better to lay off of it, or?
Well, it depends. If it's early on and the symptoms are severe, you might have to limit your activity for a short period of time, but not in the long term. In the long term, you want to do more exercise. You want to get your weight down. You want to get fit.
But is that after you get some of the pain down, or
right.
is that, you know what I mean?
initially, if the pain is severe, you're not going to be able to do those things. So that's where the medications and the injections come into play to get you back to a place where you can do what you need to do. But it's going to be exercise, stretches, the things that we all need to do to stay healthy. Muscle is our insurance policy.
I've heard that you can do the couple of surgical procedures if you have to. Is that right?
Right.
Draining it or whatever, and
well, not typically draining it. If you see 9 out of 10 people with hip bursitis are going to get well without surgical intervention, but there is an outpatient surgical procedure which I typically do with a scope, where you go in and you remove the bursa. You basically just shave it out and you release some of the IT band over it. It's an outpatient surgical procedure with 2 stitches, takes less than 30 minutes, and it works 90% of the time. But really that's for people that have just not responded at all to conservative management, such as injections, anti-inflammatories, and physical therapy. So that's going to be months down the road after you've started your treatment.
Okay.
But it is,
I appreciate it.
Yeah, thank you for calling.
Absolutely. And if you're just joining us and you have a question for Dr. Mays, you can give us a call. That number is right there on your screen, 318-219-4569. Robert, thanks for joining us. What's your question?
Yes, I have arthritis.
Hip arthritis?
Yeah, I have arthritis, but it's in my knees, I think, and sometimes I fall,
Yes, sir.
And sometimes it don't bother me. What do I do?
Well, it depends on how severe the arthritis is and how severe your symptoms are. Obviously, if you're falling and it's limiting your activity and you can't do what you need to do, then you need to go see a physician, get an x-ray. There are multiple types of arthritis. You got to figure out what type of arthritis you have. Maybe you've got a more severe form of it, but you definitely need to go see a physician. An x-ray is going to be very important to help diagnose that.
Yeah, I had an x-ray, but they just told me I had arthritis,
Well, if they just told you that and didn't offer you any treatment, I'd probably go elsewhere, but hopefully they did something to help you with your pain. Obviously arthritis, the first line of treatment is going to be, like I said, the other gentleman, medications for inflammation and pain, injections to help relieve the pain, and then it's going to be weight loss, exercise, and if those things fail, then you move into the surgical realm. And there's all kind of surgical procedures, ending up with, in some cases, a knee replacement, which is an amazing surgery that has undergone revolutionary changes in even the last 5 or 6 years. So it's nothing like it was even 10 years ago. It's a much easier, quicker, better procedure. So don't be scared to go to the doctor, go see an orthopedic surgeon and get checked out. And I'd be happy to see you if you're nearby.
Okay. All right. Thank you.
Thank you.
Yeah, thanks for joining us. And you are located in Bossier, Willis Knighton Bossier Orthopedics. And give us your number one more time.
318-212-7841.
And we do have another caller. Thanks for joining us. Lolita, what is your question?
Hello.
Hi there.
Lolita.
What's your question?
Oh, yes. Let me turn on. Hold on a second. Okay. I have a pain on my hip. First of all, I had 2 knee replacements. And they were doing okay. And a couple months later, I had this hip pain on my left side, right in the buttock. And it runs through my side of the leg. And I thought maybe it'll go away. And it's not going away. And I went to a doctor, and I explained my situation. So she gave me a shot of a steroid, and it doesn't seem like it's helping. And I've been in pain for every day. I exercise 3 days a week, maybe 2, and I try to walk as best I can, but it seems like it's not doing any better for me. And what do I need to do?
Well, did you see your primary doctor or an orthopedic surgeon?
I saw my primary doctor, I want to say about a month ago, and she suggests to take ibuprofen or Tylenol for pain, and I do that whenever I'm in pain, and it kind of helps a little bit. Then I go back to the same pain, and I'm in bed, I have to get up to turn over because it's so painful to just lift myself and turn over.
Well, since you've had 2 knee replacements, the chances are pretty high that you have arthritis of your hip as well. Like I said, the 2 broad categories I would be concerned with you would be hip arthritis versus hip bursitis. Now, you've had, sounds like excellent conservative initial management, which would be the medications and the injections, hopefully, and it sounds like you're already doing exercise and stretches, which is great. But if that's not helped you and it continues to be severe, then you need to probably see an orthopedic surgeon to get that evaluated in a little further detail. So your physician has done the correct initial steps. It's just time to move on probably to the next level of treatment. And in order to diagnose that, I would need an x-ray and to evaluate you. So once again, I would be more than happy to see you at my office if you have any problems or questions. You don't have to have a referral from a primary physician. You can just call and come in.
Oh, good. That is my second question. And I'm just so irritable, and when I get up in the morning, I couldn't walk. And the pain went all the way down to my left side of my legs, and it feels numbing, and I don't know what it is, but I have to sit down and stop whatever I'm doing, and I like to walk, and it's just so frustrating because one step it just
Well, that's
like a
that's
shooting
where
pain in my
you
hip.
need to be evaluated, because I mean, obviously back needs to be ruled out. There's a number of other issues that need to be evaluated, and like I said, call me at 318-212-7841. I'd be more than happy to evaluate you.
All right. Yes, thanks for joining us. And we have just about 90 seconds left. If someone is maybe preparing for surgery or thinking about surgery, I'll leave it with this one question. You mentioned exercise and all the other first line things to do, but weight loss is also a component as well. So briefly tell us about that, and we'll
Well, metabolically in our country, we're somewhat of a disaster. And I always tell people, don't go to a doctor with the idea that they're going to fix you. So whenever I see a patient, the first thing I explain to them is we're a team. I'm going to do my part. My part is going to be to give you advice, but you have to do your part as well, because we are all given one flesh vessel, and we have to drive it our whole life. And if you don't take care of it, it's not going to take care of you. You don't want it to break down, so you got to have good nutrition. You have to keep your weight to a reasonable level, and you have to exercise. If you do those things and you go see a physician, they're going to be able to help you. Mm-hmm. But if you think you're going to go in there, do what you've been doing, and get a good result, it's probably not going to work out well. And you don't want to be fixed. You want to go in, find a physician who's going to work with you to get you healthier and better.
Awesome. Yes. Well, we just signed, sealed, and delivered that. Thanks for joining us, Dr. Mays. And this will be on our website at ktbs.com/podcast. Thanks for joining us.
Thank you.